Welcome to the Stanford Women's Health Vodcast series. I'm Dr. Sharon Hung, Director of Women's Health for the Primary Care and Population Health Department at Stanford. From debunking myths to exploring the latest research, we will delve into the world of women's health with leading experts in the field. Today, I have the pleasure of speaking with Dr. Abha Khandelwel. She is a cardiologist at Stanford Healthcare and a clinical associate professor of cardiovascular medicine at Stanford University School of Medicine. She serves as the ambulatory clinic chief for cardiovascular medicine and the general cardiology section lead. Her clinical and research interests are focused on caring for women with cardiovascular disease, specifically around the time of pregnancy. As the course director for Stanford's first annual CME on transforming cardiac rehab, Dr. Khandelwel has also implemented digital health initiatives to improve the cardiometabolic profiles of women with a history of gestational diabetes and postpartum hypertension. Dr. Khandelwel, thank you so much for speaking with me today.
Thanks for having me, Dr. Hung.
As you know, heart disease is the #1 cause of death in women, and despite some progress over the last couple of decades in awareness, cardiovascular disease continues to be underrecognized, underdiagnosed, and undertreated in women. And we're also starting to see more cardiovascular mortality in a younger cohort. Can you talk more about current trends?
Yeah, Dr. Hung, it's actually we've benefited for quite some time from advocacy work by both the AHA and a lot of our academic centers, where when you look at cardiovascular mortality overall, the trend has decreased in both men and women up till about 2011 or so. After which, unfortunately, we've seen an inflection again, largely surrounding around the time of the COVID pandemic. But when we tease out kind of the more subgroups of the female population overall, again, the trend is declining. We notice that our treatments for traditional cardiovascular disease has been so good that those mortality trends are declining. But unfortunately, in the women under the age of 55, they are rising. And that's largely because they may have other kinds of heart disease. And I think we'll touch upon this later, but when they have heart attacks, oftentimes it's due to some alternative causes as opposed to the traditional atherosclerotic plaque. I think that's one of many reasons why, despite all of our hard work and efforts and declining mortality, there's still some subgroups that are not benefiting from that.
I see. And then we know that smoking, diabetes, hyperlipidemia, hypertension, obesity, family history, age, inactivity are all kind of traditional risk factors for both men and women. But I was hoping you could highlight the numerous sex-specific risk factors for women.
Yeah, and I'm so glad that we're finally turning attention to going beyond the traditional risk factors. So again, we've spent a lot of time as clinicians educating our patients on the very traditional risk factors, but women are unique. We experience a lot of things that our male counterparts don't. We experience pregnancy, we experience menopause. So I always tell my patients that pregnancy is their first stress test. And so if they don't pass, then that's a big alarm sign that they're going to have future risk. So when we talk about sex-specific risk factors, specifically around the time of pregnancy, we can look at things called APOs, adverse pregnancy outcomes. This is inclusive of a variety of different pregnancy outcomes. I'll name a few, but the list is long. But the ones that probably people are most aware of are things like gestational diabetes or hypertension, preeclampsia, preterm labor or birth are some of the most common ones. There are some other things as well. But those few things that, preeclampsia, gestational hypertension, gestational diabetes, and premature labor or delivery should kind of give you the warning signs that you failed that first stress test. And in fact, when we look at these women, they have both short-term adverse outcomes as well as long-term adverse outcomes as well. So in the short term, these women are almost 3 to 4-fold more likely to develop hypertension and these are young women, let me remind you. And then in the long term, they're at increased risk for cardiovascular disease, heart failure, stroke, and all the traditional poor cardiovascular outcomes. So really, I look at pregnancy as a place for early intervention. You've identified yourself young, you are young, if we can kind of change the disease course then, I think we stand to benefit the most. So with regards to pregnancy-related sex-specific risk factors, those would be what I would focus on, the adverse pregnancy outcomes. But there are other sex-specific risk factors as well. So, women are more likely to receive treatments for things like breast cancer. And so, sex-specific cancer therapies also can increase our risk for cardiovascular disease. So being aware of that when we take our history and physical. When looking at things like autoimmune conditions, that is also something that disproportionately affects women. And unfortunately, I mean, most people know that diabetes is a strong risk factor, but people forget that things like lupus are even actually quite stronger. So, and it's for a variety of reasons. One, the condition itself is an inflammatory condition. Two, when you are affected by these conditions, some of the treatments we use, like steroids and other medications, can really affect the cardiometabolic profile of the patient. And three, if you have these conditions, it makes it harder to be active and lead that heart healthy lifestyle. So I would say autoimmune disease is another sex-specific consideration. The other things I will tell you about are something kind of the psychosocial factors, including depression and anxiety, which disproportionately affect women. There have been many studies for quite some time looking at individuals with cardiovascular disease who suffer from diabetes and anxiety, and they've looked at behavioral interventions to see, does taking care of the mental health make a difference? And in fact, surprise, surprise, it really does. So we know that untreated depression and anxiety can lead to adverse outcomes in both short and long term based on randomized data that has been done largely in Europe, but I'm sure there's some US-based studies as well. And then last but not least, I think this is probably, unfortunately, the most important sex-specific risk factor, but we have to think about the entire individual. As physicians, we always think about the disease process and the biology, but the reality is that cardiovascular disease, when we look at mortality maps across the US, we can see that there are certain populations that are disproportionately affected. And that's not related to their biology or to their genetic risk. That's related to their environment and into their kind of socioeconomic status. So unfortunately, there's a lot of things that influence women's heart health that are outside of just the disease and biology. Unfortunately, there are large areas of the South and certain areas that the number of single family households led by women is much, much more. And if you look at death rates by cardiovascular disease, you can overlay those maps almost perfectly. So, I always talk about the science, but it's really important to be aware of a lot of the other issues that can impact cardiovascular health in women.
Absolutely. Thank you for highlighting the how social demographic factors can influence as well as mental health. I did read once that anxiety and depression for some reason have a larger impact on cardiovascular impacts on women than men. I also wanted to, and I also liked how you mentioned the long-term impacts of gestational hypertension and diabetes. I think oftentimes when those things resolve after pregnancy, the provider and the patient thinks, okay, that was an incident, it's resolved now, but just to keep in mind that there are still long-term impacts from those conditions. And I did want to ask you in regards to pregnancy-related complications, such as preeclampsia, would you consider something like aspirin for preeclampsia or other sex-specific risk factors to help decrease risk of cardiovascular events in the future?
Yeah, so during the pregnancy itself, we do use aspirin more and more these days for preeclampsia prophylaxis. And so that's just one of the things you asked about why there's a rise in younger women for cardiovascular disease. Well, unfortunately, just as a population, we are less cardiometabolic fit. So we're having more diabetes, hypertension, obesity, all these other risk factors. So when our women with these risk factors are getting pregnant, we are using aspirin a lot more to prevent preeclampsia. In terms of long term, we haven't yet kind of made that recommendation globally that just because you had preeclampsia, you should be on aspirin lifelong. More so what we kind of say is, if you've had preeclampsia, you better buy a blood pressure cuff and know that you should be checking your blood pressure even after baby's done, even after your insurance has expired and maybe you're not covered to be seen anymore. You should know your blood pressure. So that's kind of more prescriptive for that population. With regards to aspirin for primary prevention as a whole, there are a lot of tools that you can use, kind of different types of risk scores and risk calculators to kind of predict the patient's lifetime risk. So, you've got the ASCVD calculator, which is the traditional one many of us use. But then there's also some like South Asian specific ones. For instance, the Q-risk calculator, which looks at cardiovascular risk in South Asians. There's the MESA calculator. There's a couple different ones you can use. But generally speaking, when talking about using a baby aspirin for primary prevention, it's really a shared decision-making discussion with the patient. If I consider them intermediate or high risk, we will talk about their risk of bleeding and their ultimate risk and what features are tipping them into that category, and decide whether they should be on a baby aspirin. Maybe preeclampsia is one of a couple of other risk factors, then put them into that intermediate to high risk where an aspirin may be more beneficial.
I see. And then also in terms of primary prevention, the American Heart Association guidelines list many of the sex-specific risk factors that you went over as risk-enhancing factors, but they're not included in the ASCVD or the PREVENT calculator, which are tools to help us decide whether to initiate a statin medication, for example. How do you suggest we take these sex-specific risk factors into account as we're considering aggressive LDL lowering for primary prevention?
Yeah, I think it really depends on the population that you're seeing. So when we meet our patients for our first time, it takes us forever to get through the history because we do really want to get all of any features of their history that could be contributing to their risk, including those risk enhancing features, their lipoprotein A, if they've had a calcium score, and then we talk to the patient about what their risk tolerance is and kind of account for that as well. I do think that family history also helps navigate this discussion quite a bit for our patients, because if they saw their dad arrest in the 40s with a heart attack, they may not need as many risk enhancing features to say, I'm going to take that baby aspirin. So I think it becomes a very focused discussion with the individual, but I do think all of those features should be taken into account, but they're not all weighted the same. And I wish there was a better tool out there. I think there are some like polygenic risk scores and all these other things that are being developed to try to better calculate risk. But I think at the end of the day, it becomes a patient level individual discussion.
Got it. And I know you did a recent grand rounds on lipoprotein A, which I had the pleasure of listening to. So I know this can be a whole talk in and of itself, but can you talk more about lipoprotein A and ApoB testing, when you would start thinking about it?
Yeah, so my disclosure is, I do research in LP little a, and so I personally believe that it's a very cheap test, that everyone should have one tested at least once in their lifetime. It's cheaper than a mammogram. It's probably, I'm guessing it's less than a PSA. It's probably around the cost of a PSA. So I think that it's a very cheap test that frankly everyone should have done. But that being said, let's get to reality. And so where I find the highest yield is when we talk to patients and find risk factors where there's strong family histories of strokes, premature cardiovascular disease without other traditional risk factors. So, in young individuals who were never smokers, never diabetics, but they've got multiple family members with heart attacks, strokes, individuals that may have had preeclampsia or like have multiple siblings with preeclampsia, individuals that have calcium scores that are out of proportionate to their age or other risk factors, are probably a good place to start for primary testing for LP little a. For secondary testing for LP little a, I look at my cardiovascular patients who have had recurrent events despite optimal therapy, or disease that is more aggressive than what would be expected for their risk factors. So trying to kind of figure those individuals out and testing for them, I think LPA is probably the highest bang for your buck there. With regards to ApoB and LPA and LDL testing, it's actually very interesting because ApoB is it's an old molecule that we've known about for quite some time, and it has only recently kind of gained a little bit of attention. So when you think about cholesterol, it's a spectrum of different molecules, right? And so you've got your ApoA containing compounds, and then you kind of look across your ApoB containing lipid particles, and those include LDL, lipoprotein A, and then a class of LDL called VLDL, which is a very triglyceride-rich, very atherogenic cohort or subset of LDL. So when we check LDL alone, we're only getting half the picture, which for most people, it's okay because the majority of the population, the number of LDL will still far outweigh the number of VLDL. But there are those individuals where that's not the case. And so the measurement of ApoB is actually more reflective of the atherogenic cholesterol. So, I oftentimes use it in my individuals that are intermediate risk LDL profile to kind of understand, does it tip me to go towards treatment, or if the patient is really statin reticent, is it reassuring, things like that. There's a lot of data in the South Asian population that's a better predictor of long-term, poor outcomes. So I think that in the right cohort, it can be additive. I don't necessarily think everybody needs it. I think all of our data is still based on LDL measurements. So that still guides the majority of our treatments, but it can be additive for that cohort that you're not entirely sure which way to go.
Yeah, and I've heard a number of Stanford cardiologists now recommending at least a one-time test in lipoprotein A for risk assessment. And when you mentioned kind of tipping over for treatment, I was thinking, when I have a patient in their 40s, let's say they have a borderline ASCVD risk, I'm very enthusiastic about recommending a statin if the lipoprotein A is elevated. But what do you recommend if someone, a younger patient, let's say 20s, 30s, with mildly elevated LDL, but then the lipoprotein A ends up being high, over 30 or over 100, would you start them on a statin right away?
So that is an area of some controversy, depending on who you talk to, because again, a lot of people feel that even pediatric screening of LPA should be done. And then that brings in a whole host of questions, right? Currently, what I practice and what I advise is that if your only risk feature is LPA, then what you really need to do is work on everything else that's within your control to optimize it. And if you think about it, based on, I think it was the ERIC study, a large majority of Americans are not optimized in even three, risk factors. So just diet, exercise, and obesity. If you focus on those three things, almost every American is, 2/3 of Americans are not at their goal. So you can still work on that to try to help reduce the risk. So that's what would be my advisement. And then for those younger, like 20 to 40-year-old individuals with only LPA elevated, I do think it becomes a shared decision-making process, because unfortunately my patient panel is largely young South Asian individuals who've already had their first heart attack at 30 and 40, and their only risk factor is LPA. So not everyone, obviously, with that is going to have their first heart attack at that age, but I think you have to inform the patient of the risks, and then they can decide what makes sense for them.
Yeah, and in terms of improving those risk factors that you mentioned, exercising more, losing weight, improving diet, my understanding is that it doesn't necessarily lower the Lp(a) value, right? It just decreases your overall risk.
Yeah.
So is there any value in trending the Lp(a) or the ApoB over time? No.
I don't think so. I mean, I think, we're in the Bay Area. Everyone likes data. They like to follow data. but really you have to understand what the data is there for. So like LPA to me is a risk factor. It's a light switch. You have it or you don't have it. It really doesn't change over the course of the lifetime. And even if it does, it's going to be marginal, not anything that's game changing unless you're on therapies for it, right? And so, except for around, I should make the caveat, except for around the time of menopause, there can be some changes in the LPA. But you check it once, and then you know where your risk is, and then you guide your treatments accordingly. I frankly feel the same way about coronary calcium scores. You know, some people are like, oh, well, how do you know that I don't have more plaque? And I'm like, well, I put you on a statin, your calcium score is going to go up. It's used as a diagnostic screening tool. It is not something to follow disease activity, in my opinion.
Yeah. So, since you're bringing up the CAC scoring, I'm just curious how you're utilizing it in helping you make your treatment decisions.
I think it can be very helpful in the perimenopausal, postmenopausal female population because it does give you some idea for the statin naive patient population of where their cardiovascular risk can be. We can, kind of map them on the normograms from the MESA data and see, like, are you 85th percentile? Are you 5th percentile? So I think it can be another feature to understand whether you're going to use baby aspirin. Oftentimes we use like the calcium score of greater than 100 as a feature to consider a baby aspirin. So I think it's helpful there. The one thing I kind of pause on, and I remind some of my patients, they're testing their calcium scores younger and younger, and then they're feeling either reassured because it's zero, or potentially, depending on the person, extremely alarmed when there's a small amount there. So I think that we have to know the right population to use it in. Certain populations, the calcium score can be zero, but they can have soft plaque lining those arteries. It should not change our overall management in those younger, high-risk patients. I'm thinking particularly of South Asian patients. They tend to have more soft plaque. So if we're testing below, under the age of 50 and we have a zero score, that's great, but it doesn't mean there isn't work to do. So I would just kind of pose that.
Yeah, no, thank you for mentioning that, because I often, most of my day is spent on trying to convince people to start a statin, right? So many people are at risk. And I often use the CAC score as kind of more convincing evidence, because almost everyone has like some plaque, right? But yes, once in a while, I do have a 40-some-year-old with zero. And, for someone who didn't want to start a statin and I was trying to use the CAC score to convince them, what do you do next?
So I always tell them that caveat that, look, I'm showing you one form of plaque. There could still be, like, especially if they have other risk factors that really need optimization, you can kind of remind them that that piece has not been addressed. So they still need to work on that. And oftentimes I try to avoid ordering the calcium score in those patients because I tell them that it's not going to change what I'm going to do. So, because it's basically, I don't want them to have that false sense of security.
Got it. And let's say it's zero, and they demanded the test, it's zero. I can't talk them into a statin. When would be the soonest to repeat? I know we generally don't follow them if we know that there's already plaque, but let's say they started off at zero. Is there a time that you think it's appropriate to follow up?
Yeah, if it's zero, you haven't placed them on a statin, then anywhere from 5 to 7 years post is, I think, a reasonable amount of time.
Okay. And then on the other spectrum, sometimes I see values as high as like 600, 700s. What do I make of that?
Well, so clearly there has been something that has triggered that in that individual. So whether it's, we see that a lot in our autoimmune disease patients, we see that in our patients who have gotten radiation therapy for different types of cancers. We actually see that maybe not 600, 700, but we oftentimes see a lot of calcium, lower scores, but still age disproportionate in our endurance athletes. So like extreme sports athletes. So I think that there's a variety, and women who are taking a lot of external calcium supplementation is another group. I didn't want to forget them. So there can be a variety of reasons for that. That score always alarms not only the provider, but the patient. And oftentimes, if they are not active, they will be afraid to be active because now they're concerned their arteries are filled with calcium. So oftentimes in these individuals, sometimes we have to do treadmill testing to give them a reassurance that it is safe. And so once they do that, then you can get them on a proper exercise regimen, get them on treatment, and explain to them that, if they were to have any cardiac symptoms, that they should be calling 911 and taking it very seriously.
And is there any correlation between how high the CAC scores and like level of stenosis that might be seen on angiogram or cath, or too many false positives and negatives involved?
Yeah, so I think the data would suggest that the higher the calcium score, the higher event rates, but it's not necessarily correlated to the degree of stenosis. So as you know, like it's calcified plaque that oftentimes has been endothelialized. So it's not really within the lumen. So we may take some of these individuals who are very high risk, very concerned, take them for an angiogram, and their intralumen vessels are clean. And they're like, wait, do I have plaque? Do I not have plaque? And so you kind of have to explain to them that, the event rate is still higher, and it's really the calcified endothelialized plaque that, we're not IVUSing everyone, but if we were, we'd see that the vessel has plaque all around it as opposed to within it.
Yeah, I see. And then you talked earlier about getting a really good family history in doing a risk assessment for these patients. And I know that, an LDL over 190 is very suggestive of familial hyperlipidemia, but what other laboratory or family history clues might also suggest FH?
So oftentimes, like for family history, it's really the risk of high event rates in the family, whether it's stroke, heart attack, premature death. I always ask, did anyone die very young? Because sometimes people are like, oh, the person was in a car accident, but then if you peel back the layers, it might have been an arrest from an infarct. So kind of asking all of those pieces is important. And then on physical exam, there are certain things that we can look for, including like looking around the eyes for arcuus, and then looking at the legs for tendinous xanthomas. So there are physical exam features that should be addressed as well.
I see. And I know historically we have avoided using statins in women who are currently planning or are pregnant, but there's been some observational studies from Japan, I believe, that showed that statins may be safe during pregnancy and should be continued for patients with FH. Could you comment further on this?
Yeah, I think this is an area of gray, to be honest with you, because it was several years ago, the FDA actually removed their contraindication warning for statins in pregnancy. I think at Stanford, amongst our preventative cardiology group, I think the consensus for the majority of us is that we still discontinue it during pregnancy and breastfeeding, because as I tell my patients, having hyperlipidemia or FH, it's not a sprint. It's not a short-term disease problem. It's a marathon. It's a lifelong disease process. And the short 9 months, for the vast majority, maybe there are a few exceptions, but for the vast majority, you're accepting a risk as well. And it may not, in your lifelong disease course, change the overall prognosis all that much. So we still discontinue it for the vast majority of patients, unless there's like a very aggressive personal history of prior events.
I see. So in that case, how do you generally counsel women with hyperlipidemia who are pregnant, since we're not using medications other than the kind of the routine dietary and exercise recommendations?
Well, we also use plant sterols. You can get, plant sterols over the counter, and clostyramine is still safe in pregnancy. It's not perfect. It's like 10% reduction, but those two things are still able to be used. In the worst case, I mean, there are some studies looking at PCSK9 inhibitors during pregnancy as well. So I think there are some other treatment modalities that can be considered. But in general, I counsel the women that, look, number one, it's 9 months, optimize what you can, because you know that you're not going to be on your traditional medical therapy. Oftentimes we'll meet prior to them getting pregnant and make sure they're really optimized, their LDL as low as possible, that is safe, and then discontinue the statin when anticipating them to be pregnant. And then we talk about breastfeeding actually quite a bit. And this is, I'm probably going to ruffle a few feathers by saying this, but we've had a huge movement uh, towards kind of encouraging and sharing the benefits of breastfeeding for women, to a place where oftentimes women feel like if they don't breastfeed, they're not being a good mom. And the reality is a lot of that data, if you kind of dig down into it, which I've had to do, is not all that robust. It's contaminated with a lot of you know features like, you cannot detangle the other things that are associated with women that are able to breastfeed for longer periods of time. So I think that what we do is we have a fair discussion with the individual and say, look, you can breastfeed for as long as you want. That's up to you. But the shorter that you do, the quicker we can get you back onto treatment. And I remind them that, I remind them of the evidence and kind of how some of it is contaminated, and that, they're still being a good mom, and being there for their baby is the number one goal for any mom. And so by treating their disease, that's probably the most important thing they can do for their baby. So I kind of try to take that burden off of them and explain to them that they are still making a rational decision if they're choosing their health as the first priority after the baby is delivered.
Right. Yeah, I think that's such an important conversation for us to have with patients as providers, since there's so much just stigma around breastfeeding or not breastfeeding and how that plays into their health. And then I also wanted to ask you what your agents of choice are for like gestational hypertension or for hypertension while someone is breastfeeding.
Yeah, so we have a couple different, it kind of depends on who we're working with in terms of our OB versus MFM. Some are a little bit more hands-on and have experience and have their own preferred agents, in which case we support what they would like to do. But in those individuals that were the primary managers of their blood pressure, oftentimes we'll use beta blockers as our cornerstone of therapy. And specifically, labetalol has been a preferred choice, has been studied extensively in pregnancy. So that's kind of our first line treatments. We can use some calcium channel blockers as well. And then there's also a lot of great data on diuretics. And again, that becomes a risk benefit discussion with a patient because it may affect their milk supply. So those would be the three cornerstone treatments.
Okay, great. And then I also wanted to spend some time talking about evaluating for ACS in women. Is there anything else you wanted to add about primary prevention and what we've talked about before we move on?
No, I think we've talked about it pretty extensively.
Okay, great. So studies such as Virgo have shown that women tend to present later for heart attacks, which can limit potential treatment options such as reperfusion. Why do women tend to present later to the hospital?
That's a very, very good question. And I don't know that there's been a randomized control trial to address that specific question. What I can tell you is based on experience and anecdote. I think that number one, women tend to be older when they present with their first event. So it may be harder for them to kind of mobilize and get to where they need to be. Two, women also are oftentimes the primary caregiver of their family. So they oftentimes, and this is more, I'll tell you anecdote, we have patients who will kind of be worried about everyone else in the room before calling 911 for their own health. And there's actually a really cute video on YouTube with Elizabeth Banks and the AHA about this. And it's actually hits home to a lot of my patients because it's, the woman's like, oh, does Bob have his lunch? Is a laundry folded? Does, this person have their keys to get in the house before they'll call 911? So I think them being a primary caregiver is another issue. I think that a lot of times women may not have the typical symptoms of ACS. I mean, they almost always have chest pain. That is almost always a feature. But then they may have alternative things which make them question themselves as to whether is this really an event or not an event. So they may be nauseated, they may feel like sweaty, or they may have pain in the back or shoulder or jaw. So they're like, well, is this indigestion? Is this heart? So I think those are some of the drivers. And then, a lot of my women, unfortunately, they do have things like we talked about MI with normal coronaries. So they've had these events happen more and they go to the ER. And then sometimes the care that they receive or the treatment they receive makes them feel a little dismissed and makes them feel like they're overreacting. And so they're reluctant to go back. We know that for like the same amount of coronary stenosis or same amount of disease, women tend to have more angina. And so, we do feel things more. And so, but unfortunately, when they come and interact with the healthcare system, oftentimes they come and tell me that they were dismissed or they felt dismissed or they felt silly because the angiogram was normal or something, not recognizing that the troponin was still positive and that they may still have real disease. So I think these are just some of the reasons why they present later, but I do think it'd be interesting to learn more as to how we can improve that.
Yeah, and do we know why women tend to have more of those atypical symptoms you mentioned than men? I've heard that we acquire coronary disease a bit differently. There might be more diffuse disease in women.
Yeah, so when you think about like ACS and heart disease, we always talk about atherosclerotic heart disease, okay? So it's like plaque buildup in the arteries. But going back to what we talked about earlier about having a rising incidence of heart disease in younger women, they often have something called MNOCA, myocardial infarction with normal coronary arteries. So they come in, they have some symptom, they have a positive troponin, maybe some EKG changes plus minus. They go to the cath lab and their arteries don't have plaque. So that is still a different disease process than that traditional atherosclerotic disease. So it stands to reason they're going to have different symptoms. So when you kind of break that cohort down, it can be broken into kind of microvascular disease, which is like kind of the disease of the small arteries, kind of the diffuse disease you were describing. It can be vasospasm or endothelial dysfunction, which is kind of abnormal reactivity of the cells that line the arteries. It can be things like SCAD or spontaneous coronary artery dissection, where the artery actually tears, or it can be something like stress-induced or Takotsubo's cardiomyopathy. So there's a lot of different things, or like myocardial bridge. I mean, I could go on and on. There are a variety of reasons of why these things all lead to the same clinical picture, which is a heart attack. But each of these things are going to have different signs and symptoms that come with them. So, that's why I believe that they tend to have these other symptoms, is because oftentimes they're not dealing with a traditional atherosclerotic disease process.
Yeah, I have definitely seen what you've noted where women present with chest pain to the ED, the angiogram or cath is clean, and then it's determined as non-cardiac, and then we move on from there. So I guess now that we're raising awareness, what do you suggest primary care providers do next when one presents like that to the ED and then comes back to us in clinic? How do we start to work up or think about things like microvascular dysfunction or coronary vasospasm?
Yeah, so I think so assuming a clean angiogram and a positive troponin with a clinical syndrome of chest pain, then we have to kind of go back and think, well, what is the likely etiology? We're lucky to be at Stanford. We're at a coronary care center. We have every resource to our disposal, but that's probably not practical if you were to apply it for the entire population, right? So if you look at an entire population of coming into their primary care office, not everyone needs advanced vascular function testing or, thousands of dollars worth of MRI testing to diagnose their condition, because ultimately the treatment is going to be the same, which is risk reduction, monitoring those same disease modifiable risk factors like diabetes, hypertension, obesity, sleep apnea, exercise, diet. So really aggressively working on that and trying to decipher, well, do I think this is microvascular disease versus vasospasm? I think that's very reasonable because those require different medication treatments as well. So if the individual is having sporadic angina without really any exertional component, it can come on at any time, it resolves at any time, it may have some more atypical features. We oftentimes treat that more with like calcium channel blockers. Versus if the person has all the traditional hypertension, obesity, hyperlipidemia, they have the very exemplifying angina that is similar to obstructive coronary disease, but their angiograms are normal, then we could potentially presume microvascular disease, work on those risk factors. If we're not certain, that's when the role for advanced testing comes into place. So, at Stanford, we're blessed. We can do, certain types of stress tests to look at whether it's the microvascular dysfunction that's the issue. So we have stress MRI that can look for that. It looks at the blood flow down the vessels at rest and at stress and can quantify whether it's the microvasculature that's the issue. We have nuclear medicine tests that can do a similar thing. And then last but not least, we have interventional cardiologists who can do like a 4-hour angiogram, putting all different kinds of wires, catheters, medications into the blood vessels and test for all of these things. And that way the patient can walk away with a definitive diagnosis. So in some ways that can be very helpful as well. But again, I don't know that everybody needs all of those things.
Right. Okay. Yeah, I understand. I think it's good to get a sense for what the cardiologist might order, consider. And then you mentioned potential calcium channel blockers for coronary vasospasm and lifestyle modifications for microvascular dysfunction. Are there certain medications that should also be used for microvascular dysfunction? Are they the same medications for coronary artery disease?
It's much the same as coronary artery disease. It's beta blockers and statins are the kind of the cornerstones for that. And then kind of risk factor modification. There are some other more advanced medications like ranolazine or Ranexa that can be used in like drug, as kind of end stage drug resistant microvascular angina. It can be helpful in a small cohort there. We haven't talked about some of the like other causes, but like things like myocardial bridge can also cause chest pain in the right patient population. So oftentimes we'll use more of like the vasodilator beta blockers like nebivolol in those patients. So there are some subtle differences. If you're interested, I can share with you a paper that kind of we had written. There's like a nice diagram of what evidence is available for each of these conditions on what therapies to utilize.
Okay, great. And then speaking of all these guideline medications, whether it be a statin for primary prevention or let's say an ACE inhibitor for heart failure, women tend to receive less guideline medications. What are your thoughts on this?
Yeah, I have so many thoughts on this, Dr. Hung, and many I should not say out loud. But what I will tell you is that, it's very hard to treat individuals who are high risk. And women, oftentimes, as we discussed, are older at the age of presentation, have many, many more comorbidities. There's polypharmacy involved. And so that's one piece of it, I think, for sure. I think the second piece of it that we as healthcare providers don't want to believe, but there's evidence to show that women's, generally speaking, their risk factors are underappreciated by their treating clinician. We know that hypertension is more prevalent in women. We know its risk for cardiovascular disease is much more impactful than it is in men. Yet we are not prescribing, treatment as it should be. I think that's one piece of it. Okay. So when looking at cardiovascular disease, we're underappreciating the disease and the risk factor in our women, which is why we're not prescribing it. Women aren't taking it, even if we are, because they're taking 10 other medications and also managing all the other things they have to do for their family. I think that's one thing. When we look at heart failure, that's another issue. So again, women are older when they present, but they're also more likely to present with something called heart failure with preserved EF. So HFpEF, as opposed to heart failure with reduced ejection fraction, where we have very good medications and adherence to goal-directed medical therapy, but oftentimes that happens in a younger cohort and also more often in men. So I think that's another piece of it. A lot of our treatments have been studied in that population, the heart failure with reduced EF. So a lot of that GDMT is applied to this male cohort, but hasn't yet made its way into that HFpEF population, even though there is data saying it's of benefit. So that's one piece of it. The other piece of it is, again, being more frail, being older. Oftentimes they have side effects. They can't tolerate it. Their blood pressure drops more, all of these things. And then last but not least, I will go back into that socioeconomic, social determinants of health piece. These women that are older, oftentimes once, if they are alone, if they are not taking care for their family, they may or may not be in a poverty type situation where they can or cannot afford these medications. So I think that that's another huge component as well.
Yeah, I think, it's always so important to be aware of how these socioeconomic factors and how the, familial structure and things like that impact how well women take care of themselves. And I'm just wondering if you have any suggestions on how primary care providers can better support these patients and so that we can get them on appropriate therapies.
Yeah. So, um, one thing I will say is that like we've done studies looking at postpartum like disease modification with digital devices for like hypertension, gestational diabetes. And what we found was the women that were most likely to get to their goal or maintain that goal at 1 year, they had a partner with them at the visits. So I will almost always ask the individual if she comes alone or with the baby alone, can I call someone on the phone? Can I call your partner? Can I call whether it's your mother, your father, your partner? Can I call someone who's going to help you meet that goal? I do the same thing with my elderly patients. Even when they say that my memory is fine, I was like, I trust your memory. I just want a second pair of ears so that they can help you get to what we need to get done. And I think that, that helps get buy-in from their support structure. And if they don't have a support structure, then that alarms me that I need to help keep a closer eye on them or involve social work early or help them identify a new social structure. If it's not their family, then maybe it's their church group, maybe it's a neighbor, but really women do better in communities. They do far better in communities than they do alone. Um, so we know that like at those visits, at the primary care visits, really finding that partner for them, I think is important and getting their buy-in. So, there have been times at the postpartum visit, I look directly at the spouse and say, are you going to let her go out for half an hour every day by herself for a walk? And then when he says yes, I'm like, okay, I'm documenting that you are doing this. And actually, I think it impacts them and they take it more seriously. They realize that they are a partner in their spouse's health too. So I think that's a small thing to do. I think when it comes to some of these other systemic features, it's hard to really make those changes at a clinic level. I think we have to do that as a society and kind of use our voting powers to make sure our citizens have access to affordable medication and infrastructure that supports their health.
I love that tip about trying to get the partner or another family member involved. I'm really glad that I asked you that question. And so I also you mentioned earlier that something that's unique to women, of course, is that they go through menopause. So I just want to spend a few minutes talking about that. And there's numerous physiologic and metabolic changes that occur during menopause, of course. Can you talk about how these changes affect cardiovascular risk?
Yeah, so we know that premature menopause is a risk enhancing feature based on the guidelines you discussed earlier. So we always ask that in our clinic. And then once we identify that, what we tell individuals who haven't yet, if they haven't yet been through it, is that look, around this time, things are going to change. And for some people, it'll be minor. For others, it'll be significant. So first you have the cardiometabolic changes, which is where my expertise lies. But then there's also these hormonal changes, which don't support helping you lead like a heart healthy lifestyle. So from a cardiometabolic standpoint, blood pressures can change, weight distribution, adiposity, muscle mass, LDL, your lipids. I alluded to the LPA. That's like one of the times it can be changed. Blood sugar metabolism. All of these things can kind of get, for lack of a better term, worse postmenopausally or perimenopausally. And then on top of that, you add in kind of the hormonal changes where you may have, vasomotor symptoms, sleep deprivation, hot flashes, mood changes. It can really impact how, if you can adhere to like a well-balanced diet, exercise, and really feel good about yourself. So I think it's kind of a twofold hit for women around that time. And so, we always advise that they discuss with their primary or their OB about whether they are a candidate for MHT and like whether it's safe for them. And in some situations it is, and some it's not. but there actually are newer therapies also out there that are non-hormonal based for vasomotor symptoms. So like I think there's a lot more treatments than there were when I first started here. And so I think my hope is that we'll continue to do research and learn about this phase in a woman's life, because I think a lot more information is really needed on how best to manage.
Yeah, and I know you're not the one prescribing MHT, of course, but and I know that for patients with a history of stroke or MI, that's an absolute contraindication. But from, I guess, from a cardiologist perspective, what other patients might be too high risk to consider menopausal therapy to help manage their vasomotor symptoms?
Yeah, so in general, we preferred them to be younger as opposed to older within kind of that first 10-year period of menopause. And then if they have a very strong family history also of blood clots or MI or stroke, then we often really have to think twice before we're recommending it for them.
Yeah. And so thank you so much today for reviewing kind of the sex specific risk factors, the different presentations of ACS and Minoka that women may have. I'm just really glad to be raising awareness with you. I trained at one of the major, heart transplant places, and no one taught me about any of this. So I've kind of been learning along the way, and I'm glad to kind of be sharing that information with you today.
Well, I really, really appreciate you bringing attention to this, Dr. Hung, because honestly, this is obviously something I'm very passionate about. And as a cardiologist, as one individual provider, I can only do a little bit of impact. But primary care, I mean, like that is where the change happens, in my opinion. You are the front line, you're the first defense for these women. You're the ones who see them, before they've already had their event, hopefully, and can really modify the disease course for these women. And I think it's really, really critical what you do. So the fact that you're putting attention on it brings me so much joy.
Well, thank you. I learned so much from you today, and I really appreciate your time today.
My pleasure. Have a good one.